dive into our next topic of conversation, which is going to be applying functional capacity evaluations to ultimately facilitate a return to work. So very briefly on me, my name is Chris Scoma. I graduated PT school in 2010, entered into the outpatient orthopedic space immediately after school, and then found myself in the occ health realm, initially doing post-offer employment testing and job demands analyses for a zinc mine in the middle of nowhere, Tennessee. And so very much had a crash course in job demands analyses, but had an interest in it from there. And then I've been with Results Physiotherapy, as I mentioned, for a number of years and have served in a variety of clinical and non-clinical roles. And ultimately with the acquisition of Results by Upstream Rehabilitation, had a chance to oversee clinical quality and education for 1,200 clinics across 28 states. I hold advanced certifications as listed there. So as I mentioned, I've served in the outpatient orthopedic space for my entire career. And really, there was an 8-year period there where I pretty much exclusively did occ health, workers' compensation, FCE performance and training. I've had the pleasure of learning a variety of FCE platforms. We'll be discussing today the Results Physiotherapy proprietary product. We'll kind of get into some of the methodology there, but have also dabbled in job demands analyses and post-offer employment testing and implementation, both in the performance and operations side of things, and then have done quite a bit of clinical and non-clinical education in the occ health space. So the purpose of our discussion today is to highlight an example of interdisciplinary collaboration to facilitate a safe return to work. And in this particular case that we're going to talk through, it's relatively complex, and that's sort of why I chose it, was that it was not your sort of everyday run-of-the-mill, low back acute sprain strain. And so there was quite a bit of opportunity for a variety of stakeholders to get involved. And I believe that by doing so, we ultimately put the injured worker in a position to return to the job that they enjoyed. And it was a great example of sort of adhering to current best practice. And then I'd also like to talk on, I've been doing this for a relatively long time and had a lot of learning on the job experiences. I've certainly been chewed out by a few nurse case managers and or physicians in my years because there was no, singular resource for all things occupational health. And so I think the implementation of the OHP curriculum, you basically condensed what it took me 10 years to learn into 2 manuals and a Capstone project. So I'm very much excited to see this resource be available. And I've learned, I'm always learning, but I've learned quite a bit through the process of reading all of this coursework and discussing with like-minded peers. And so I'm hoping to just spend a little bit of time highlighting opportunities for updates to our FCE clinical product based on what I've learned via the OHP program. So we're going to discuss this case first, just to kind of set the stage for what I ultimately, when I got involved eventually as the FCE provider. So I will just mention with this case description, I had no direct involvement in the care of this injured worker. And all the things that I'm sharing here were basically outlined via a medical records review. And then the injured worker did seek care at one of our clinics. So I knew the clinician that treated them. So we got a little bit of insight there as well. So this injured worker sustained a right shoulder injury in a manufacturing role. Ultimately, conservative care did not change their symptoms at all. Interestingly, imaging came back negative for pathology. And so this individual had no concerns around, atypical findings, or there were no, yellow flags as it pertains to psychosocial concerns. And so luckily, this individual was given the benefit of the doubt, which I can say in my practice is not always the case. But ultimately, exploratory surgery was authorized via workers' compensation, which again is not something that I routinely see, but it was performed, and ultimately there was a labral tear that was uncovered. That repair was performed, and unfortunately, the injured worker again gets back into therapy and is just not progressing well. And so a lot of scar tissue, range of motion was just pretty abysmal. And so there was a second surgery to get in and to breed. They were again returned to therapy for post-operatively, but continued to struggle with functional progression. You know, I think what's interesting is if you look at the clinical practice guideline around factors that will delay return to work, the fact that the job was physically demanding and there was no modified duty option available were already significant factors that put this injured worker at risk for delayed return to work. And then it's also a complicated case on top of it. So, you know, as I mentioned, they get back into therapy, they're progressing, but it was basically in the trenches, slugging it out, trying to get this individual to progress. And so, as you might imagine, the payer, the insurance carrier, is starting to get a little weary of the tab heading north of what they would like. And again, in Tennessee, where I practice, we are an ODG state when it comes to treatment provided to patients. And so again, they are going to look to leverage those ODG guidelines around therapy interventions as well as utilization. We were way north of all of those. And so the payer was considering suspension of therapy, looking to basically kick it over to UR, hoping that it's going to ultimately end in MMI, permanent impairment rate, permanent restrictions, and likely looking to close this claim. And the therapist, the physician, the nurse case manager all felt like this individual was frankly far too young. And there was concerns, around the fact that they did not possess a particularly extensive educational background. And so manual labor jobs were really going to be what was likely going to be available to them. And there may be some difficulty with getting this individual gainfully employed if some significant restrictions were put in place. And so there was great collaboration. This is outlined within the CPG as the best practice to facilitate basically getting everyone on the same page. And ultimately an FCE was ordered to outline what those functional limitations were, but also add some credibility to the legitimacy of the case, because oftentimes, again, in the work comp space, there is some concern around legitimacy or willingness to return to work. So very briefly here, I just wanted to highlight key components of a functional capacity evaluation. This is outlined by the 2018 best practice guideline. And so, again, you can see when you look at the key components compared to what the Results Physiotherapy proprietary product is, there's significant overlap there. And so, again, looking at an intake interview, medical records review, physical exam, and then content valid testing. Functional testing. That's the big important thing there, is how is it going to be applicable in the testing environment? And then does that carry into the workplace? So when it comes to our intake interview, obviously, again, I'm doing this is where I'm basically getting involved in the case. And so I've done my medical records review. I've had an opportunity to cross-reference their subjective report of what has occurred from the date of injury to the day of the FCE with their medical records. And again, this is important because there are times when those stories change, and that can certainly be cause for pause or concerning. And so we get an opportunity to cross-reference that, as well as review the job demands analyses if one is provided. I can tell you, again, in the state of Tennessee where I practice and with the payers, we receive a lot of our FCE referrals from. If we get a job description, it's rare. And if we do get one, they're not particularly good. And so we're going to, on the next slide here, dive into what I was provided with as a means to, again, try to streamline what I might test as part of my functional capacity evaluation. We're going to confirm the completeness and accuracy of our intake paperwork. This is important because, particularly in this case, we're implementing the DASH as our functional tool, and rationale being that that information can be used for impairment ratings if that ends up being needed at the end of the FCE. So some sort of functional outcome measure is going to be needed. And in the case of the DASH, if they're not filling it out in its entirety, it's not particularly useful. We're going to review their health status to identify any comorbid health conditions. Again, we live in the South here, and so it's not uncommon for resting heart rates at 115 and BPs 190 over 110. And so obviously, that would be of serious concern to put someone through a functional capacity evaluation if those conditions are not being managed appropriately. And so, again, in this particular case, there was no particular concerns. This person was otherwise young and healthy, minus their shoulder. The goal of the initial conversation is to develop that, again, understanding of their history, but also to develop a therapeutic alliance. Again, we know that from the 2021 CPG recommendation, this is incredibly important. And I think, yes, it's important in the therapy space, but when it comes to functional testing, that is going to be, by definition, at a safe capacity. It's important to build that rapport and make sure that the injured worker understands that we're not there to try and trick them or manipulate results. We're there to try to assist them in outlining their functional capacity. So we have an opportunity to convey the purpose of the FCE, outline full disclosure of test procedures, and then outline our informed consent. Critical job demand analyses. We're looking at, again, not a particularly elaborate one. We're looking at overhead reaching occasionally, waist to 75 inches at 53 pounds from a lifting. And again, that 53 pounds on a carrying perspective, frequent standing and walking. I'm going to just highlight here, again, in my practice, we're almost always doing in any occupation FCE. And the rationale for that is that job-specific FCEs, we just don't have enough information to do them. On a grip testing perspective, so this is part 2 of our FCE, we're going to highlight, again, the Stokes protocol as looking to assess a bell curve. This is used in some capacity to look at sincerity of effort. We expect certain clinical presentations, and then we're looking at coefficient of variation and rapid exchange comparison. Using the table to your right, I'm just going to outline briefly that there was no significant concern with this individual on their grip testing. Again, things were as they should be expected. I will mention moving forward that we've decreased our reliance on this as a measure of effort simply because of updated literature considerations. And so I still think it's meaningful to assess because there's certainly information that can be part of the larger puzzle and applied in that fashion. But we've certainly decreased our emphasis on how much we rely on this as a sole means to determine sincerity of effort or level of effort. Our physical exam is going to focus on what you would expect: active range of motion, passive range of motion, manual muscle testing, neuroscreening, palpation, and special testing. I'll highlight, as outlined in the AMA guides, and again, in Tennessee at least, using the 6th edition to impairment, it's not likely that you're going to need to use range of motion as your primary means for establishing impairment, but it can be applied in some instances where certain diagnoses do not fit a diagnosis-based impairment. So very much important to gain or to gather that information. And again, this is going to provide us another opportunity to assess consistency in their clinical presentation. So, do those range of motion measurements fall within 10 degrees of the average as outlined by the AMA guides? So in this case, again, had a big opportunity to evaluate the injured worker, confirm the legitimacy of their subjective report. There was objective clinical findings that sort of match what you would expect to see. And then it also gives me an opportunity to cross-reference when we get to the functional testing. If they have a range of motion restriction, is that consistent when we look at overhead reaching or overhead lifting? So just going to, again, briefly highlight what our testing looks like. And so sitting and I forgive, it's a little bit harder, I know, on the screen to maybe see some of the narrative, but the big take home here is we're looking at things that would obviously be important from a job perspective. So sitting and standing, we're not individually testing that. That's going to be looked at, again, basically observed. The injured worker, again, this is an upper extremity injury. Most of the times in those cases, folks fly through this aspect of testing because you wouldn't expect them to have problems with stair climbing on an upper extremity injury. But we're assessing each of these things at the parameters listed. You'll notice we're also looking at time to complete the task, what their heart rate response was, their rating of perceived exertion, their subjective report of pain, and then also looking at, from an observation perspective, clinically, what are we seeing in terms of any sort of biomechanical concerns? And ultimately, all of this data will support our recommendation of seldom, occasional, frequent, or constant when it comes to providing return to work recommendations. And I'll highlight, I think, again, over the years, I've tried to find some sort of standardized, like, what should we be doing for each test to have good carryover and be demonstrative of, if they score this way in an FCE, what's the likelihood of them performing at that level 6 months from now in a work environment? And there's just not good literature to support that. And so, again, I think even the OHP content, I highlighted that, we're taking a multifactorial approach, looking at their subjective report, their health records, their clinical exam, and their functional performance results to provide some sort of recommendation. On the material handling side of things, you can see just, again, quick picture of what our lifting station might look like. How we structure this, again, so 1 repetition max. There's some research out there that shows that there can be some correlation there. I personally have never been a huge fan of looking at 1 repetition and drawing all of my conclusions from that from an occasional lifting standpoint, simply because they may be performing it more frequently than that in the job environment. And so our sort of standard protocol is we're going to perform 1 repetition at lower weights, gradually increasing. The injured worker has the opportunity to say yay or nay on if that weight increases. And when they feel they've reached their safe functional max for that lift, we then perform 4 additional reps for a total of 5, giving them approximately 30 seconds of rest, so that we are in fact looking to establish what is their occasional lifting tolerance. And so you can see floor to waist, waist to shoulder, waist to overhead, bilateral carries, unilateral carries, pushing, pulling, and then the pile test, looking to establish, well, what does their frequent lifting look like? And then how does that compare to their occasional lifting to see if there's good consistency? I outlined, at least in Tennessee, a large portion of FCEs that I will receive are focused more on, is the injured worker legitimate in their subjective reports? And I hate to say that, but that's kind of the nature of it. We know that from the literature, there's not a huge prevalence of secondary gain or outright fraudulent cases out there, but the payers don't always see it that way. And so there's a big emphasis on how can we objectively outline the consistency observed during testing. And so there's going to be psychometric considerations. Ultimately, is the injured worker's perception of their ability parallel with what reality would suggest? And so we're going to look at the Ransford drawing. There's going to be Waddell's and Sobel's when appropriate. Again, in the case of this particular injured worker, there were no psychometric concerns. Everything appeared to be on the level. We're looking at observational consistency, as I mentioned earlier, range of motion. During physical exam, is that carrying over into their functional activities? So again, we might see somebody who demonstrates 80% of shoulder flexion, but then grabs their jacket off the coat hook at 120 degrees. And so again, in this case, there are 0 concerns with any of those types of behaviors. So good observational consistency. Physical exam findings were consistent with their known pathology and medical records review. Their grip performance, as I already indicated, was pretty straightforward. Values look good there. We're looking at cardiovascular response in reference to RPE. So again, if someone's telling you their RPE is 18 on a Borg scale, but their heart rate's at 80, there's a little bit of a discrepancy there. And so we're looking at opportunities to see if their subjective report is reliable. I already mentioned pile testing for cross-reference. Again, you're looking at frequent lifting there. And so there are instances, it wasn't the case on this particular FCE, where an individual scores higher or lifts more on a pile test than they outlined they could do on the occasional lifting task. So there would be a discrepancy there. And then finally, we're looking for an appropriate material handling relationship. You would expect someone to be able to carry more than they can lift overhead, unless there's some known pathology to outline that. So there's just a few different things that we're looking at to determine, has good effort been performed. In this case, there was no concern. So we get to the end of our FCE. Ultimately, the individual did not meet the requirements of their job. And so we were able to outline to the stakeholders that ultimately there's an 11-pound discrepancy and they were not going to be able to return to work. We were able to outline that they were putting forth consistent behaviors through the FCE and their effort was noted. We advised work conditioning at this point. Work conditioning was performed at 5 times a week for 3 weeks, gradually increasing from 2 to 4 hours. There was a big emphasis on closing that functional gap. And upon completion of those 3 weeks, they returned to me for an abridged FCE. You'll notice here again, based on 3 weeks of work, 3 weeks of work conditioning, they were able to effectively, upon retesting, meet that essential job function. And you'll see there, again, 55 pounds was their final FCE at that waist to 75 inches. So definitely a successful case here and as it pertains to return to work at full duty. On the billing side of things, the first FCE was billed at 16 units of 97750. That's pretty standard across the state in terms of how our payers want that billed. Work conditioning outlined there at 97545 and 97546. And then again, we have a lot of awesome relationships with our payers, and so was able to negotiate a single case agreement to get a second FCE performed at a reduced rate for the payer. So case reflection, like I already mentioned, this was a great example of a really complex case that could have gone south and left the injured worker in a position where they were unable to return to work. We were able to circumvent that by using a functional capacity evaluation to outline both the legitimacy of their functional complaints, as well as highlight that functional limitation. We built a targeted work conditioning program and helped resolve that deficit. And then ultimately, this provided, again, just due to the relationships that we have in the state, an opportunity to discuss with the employer, hey guys, your job demands analysis is awful. Like perhaps we could have saved you this injury because, again, and not that you should ever take someone at their image, but this particular individual did not fit the physical description of someone who would be doing occasional 53-pound overhead lifting. And so perhaps they hired someone that wasn't particularly well equipped to perform this job, and that landed them in that hot water of having this injury. So very briefly, opportunities for improvement. I think, again, the clinical practice guideline has highlighted how important some self-report functional assessments can be. So we'll talk briefly about that. I want to highlight heart rate reserve as well as updating our recommendations to be more aligned with the updated ORS classification system. So on the self-report functional assessment, the CPGs outlining the workability index, FABQ, these are reliable and validated things that we could be assessing to enhance, is that individual's perception going to be a challenge when it comes to getting them back to full duty? And then Rick looped me in with the AMA 6th edition when it comes to impairment ratings, relying on that PROMIS physical function tool. So again, opportunity there to be more aligned with current best practice. Our heart rate assessment is based off of outdated ACSM recommendations. And so we're looking at generally using 60 to 70% as an age predicted max heart rate as an indicator of, is the individual performing with some level of effort, 85% being the cutoff. But there are some problems with that, as you might imagine. So as an individual ages, they routinely don't have to participate, or they routinely have an elevated heart rate with less work. And so is that really the best way to assess them? And so I think there would be huge opportunity to implement this estimated percentage heart rate reserve by age and work duration as outlined by the Occupational Requirements Survey. And then finally, our recommendations for category are based on outdated Dictionary of Occupational Titles definitions. And so we need to update those to be more aligned with ORS. We also need to be adding seldom as a opportunity. Again, our current parameters do not include that. And then on the frequency front, again, something that I learned in the OHP content here, just reframing based upon some of the AMA information, reps per hour being equated to less than 12 as occasional, 62 or to 12 as sort of frequent, and greater than 63 reps an hour as constant. So just some tweaks, I think, that would enhance the quality of our product. So thanks for listening. I think I ran right up to my time limit there. So apologies if I'm a minute or two over. Are there any questions?
Thanks, Chris. Great presentation. Enjoyed the perspective of how actually some of the manuscripts have informed you too of some changes that may be in the functional capacity evaluation that you're running. But I liked all the detail that you had given in presenting. Let's open it up to questions. I see Amanda has her mic off.
Because this was a unilateral injury, do y'all incorporate any unilateral testing as far as the functional job demands, especially when you're looking at maybe a dominant versus a non-dominant side?
We certainly can. I think that's oftentimes left at the discretion of the treating clinician. And to your point, the particular job demands in this case required a two-hand lift. So I did not in this instance outline that, but that can be applied if the FCE clinician finds it relevant to the job description.
Other questions, Rick?
Yeah, great job, Chris. It's such a complex topic talking about FCE, and in particular, I think we've tried to frame the difference between the job-specific FCE versus in any occupation kind of FCE. And the information you receive, thanks for highlighting that the information received from the employer really kind of puts you at a disadvantage if it's crappy information, right? I mean, as a certified professional ergonomist, I mean, the thing that jumped out to me first about this case was they're having someone lift 53 pounds to 75 inches. And whether, regardless of what type of materials handling tool, ergonomic tool that you apply, that's going to come out as a hazardous lift. Wouldn't you agree, our ergonomist from Spartanburg? I mean, come off mic and we could discuss, but 53 pounds at 75 inches is, I just think as physical therapists, we have to, that should be a job red flag in terms of how the employer is presenting their information, that maybe presents a real opportunity to create a direct-to-employer relationship to lower the bar. Because I know that the main reason why I'm successful as a transitional work therapist is I'm oftentimes lowering the job demand by improving job, not just for that worker, but all workers. So that was a big, I wonder, Chris, just to ask you a more direct question, when that comes down the pike, how do you write your summary to provide kind of like a disclaimer that you didn't get good information? I mean, do you bring something into your summary that gives a disclaimer that hey, there might be an ergonomic opportunity here?
We have to be very careful about that, particularly with the vast majority of our FCE referrals coming from networks. There's often quite a layer or barrier put up in terms of our ability to communicate directly with some of those stakeholders. And oftentimes we're even blinded so that we can't backdoor it. And so I think, to your point, like in a perfect world, yes, we would have to be very careful, and pragmatically, I would be concerned about upsetting referral sources. And so there is that element of, we're often going to do that any occupation FCE as a way to just articulate, here's what they're capable of, and then leave it to the physician who has typically a bit more information than we might to make recommendations, as they see fit. So, but it's challenging in Tennessee just because of where we're getting our referrals from.
Yeah, I know typically what I have to do is include a short statement saying basically, because the job information was not accurate or we didn't have direct validation by ergonomic, that I had to rely primarily on the worker as the job expert, and that especially when they don't meet the demands, because at that point, one solution might be like more therapy or more work conditioning, but another might be just to encourage a review of that task to see if it can be brought ergonomically within reasonable guidelines, just so we're not returning broken workers to broken jobs.
I mean, I agree. There's a lot to be desired in terms of how, some employers, again, at least that I've had the opportunity to discuss with, are often more concerned with just finding bodies. Because they've even gone so far as, and again, this is a little off topic, but to waive certain screening of employees because they just need bodies. And so trying to have a conversation with them, and that was kind of one of my questions again to Amanda earlier, was just like, we sometimes have a hard sell on prevention and or updating some of these requirements because they're more focused on quarterly profit numbers than they are looking at 3-year longitudinal, how do we showcase our cost savings? And so it can be a bit of a reach to change their priority within the current climate.
You had an opportunity at any point to go into any of the maybe more common companies that are referring associates to you to have a better understanding of you observe their job demands to be?
So for this particular case, no. We had some conversations after just because of some of the, again, networking that we've done in the state. But yes, so for the companies that I was involved with, say, the job demands analysis and post-offer employment testing, like that fundamentally changed how we provide recommendations on our FCEs in those cases. Although, as you might imagine, because that employer was being far more progressive in their implementation of total worker health, we got a lot less FCE volume from them because people just weren't in need of it. Injuries were down and things were being managed more effectively because of that proactive approach.
Jamie, do you have a question?
I may have missed this, but does the particular company that has this very large lifting expectation, do they do any kind of screening once they do offer? They don't do any?
No, and again, it's part of, I think I mentioned briefly that we had a conversation with them about, again, like there could be huge opportunity here to screen your workforce out and save you some money. And their biggest thing was, I don't think they've been fully staffed in like 18 months at the time of this. And so it was, we hear what you're saying. We love the idea, but like, it's just not the climate to where they can take those approaches, unfortunately.
Yeah, we had a similar situation where we did a lot of that. And then because of the retention issue, they did away with it. And so now we're seeing kind of on the back end that the injuries are going up. The retention is honestly worse because now these people are unable to hold their jobs successfully. So it's really kind of hurt them in the long run.
Well, and I can say, again, too, this is a little off the FCE topic, but it's just funny because you'll have those conversations. And I think any direct deal we've done with an employer, we have these conversations, nothing comes of it. And 18 months later, we get the ceiling's on fire. Can you please come in and do this yesterday? And so, who knows, this particular employer may end up circling back. Because again, the way that they're doing things is certainly putting individuals at risk.
Yeah, I just wanted to share one other perspective. Chris is in a state, in Tennessee, right, Chris?
Yes.
That the employer can direct care. And because the employer can direct care, it's sort of a mixed blessing. If you're on the provider end of things, you tend to have more referrals coming through workers' comp therapy networks, where you got a middle person that's kind of taken a share of that case or responsibility, and so you have to respect that relationship with that type of entity, but also you also want to, I mean, there's a benefit to having a direct contact with the employer. And, you know, one possible way to manage a situation where the referral comes in and just right on the written job description, it says 53 pounds at 75 inches overhead, which is above the ACGIH threshold value for lifting. They don't go above, anything above 72 inches is considered a hazardous lift. I might be inclined to try to see if I could do that FCE at the work site, where the first part of the FCE is to review their functional job demands and then retreat to a private conference room to do, you know, assuming that you have a mobile equipment set that allows you to do that. And so, like, for example, that shelving unit, Chris, that you displayed, you know, when I do functional assessment for overhead, I put a piece of painter's tape on the wall and have the person lift the tote to that painter's tape mark and make sure that that mark corresponds to the job specific, maybe height demand for like an overhead lift. But I think if, I think as an emerging area of practice with FCEs, the ability to do them at the work site when it is a job specific FCE is a really valid, a more valid approach. And then also, I have a feeling that if we can do an impairment rating as a component of these chronic, long dragged out cases too, that will also provide another value added reason for the employer to refer them for the FCE, because they don't have to pay for another independent medical exam and they have it validated with functional testing.
Yeah, all great points.
Great job, Chris. I really enjoyed the presentation. We'll at this point, we'll move into the panel discussion afterwards and kind of finish up from there. So thank you all, and we'll go to the next session.